Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you a unique conversation about joint manipulation. This time, our guest is Dr. Sillevis. He completed entry-level physical therapy training at Hogeschool Haarlem in the Netherlands and Doctor of Physical Therapy training at the University of St. Augustine. In addition, he completed manual therapy, primary care, and craniofacial, neck, and head specializations. As if that were not sufficient, he also earned a PhD from Nova Southeastern University, fellowship training with Regis University, and he is a board-certified orthopedic specialist. Among other accomplishments, Dr. Sillevis is an assistant professor at Florida Gulf Coast University and remains active in clinical practice. We invited him to the podcast today because he was the primary author of a poster from this past year's AAOMPT conference. The title of the poster was The Effect of Spinal Manipulation Audible Pop on Brainwave Activity. Of note, this poster won a first place award. I'm positive that this will be an interesting conversation, so, without any further delay, let's get to the interview. Dr. Sillevis, welcome to the podcast. How are you doing today?
Very good. Thank you for having me on this podcast today.
Well, it's our pleasure to have you here, and thank you for joining us. And congratulations on the conference poster. It was a first place winner, and I will say it was much deserved as a winner.
Thank you.
I found the topic that you were writing about in the poster to be superbly interesting, and I'm really excited to dive into the topic here. Speaking of which, this isn't a standard new fellow in training poster. It was far more advanced, and that point having been made, can you tell us about what led to the developing of this project and conducting the pilot study that was represented in this poster?
Yes. So when I went to my fellowship training, 2008, 2009, one of the things that stand out for me is the fact that both clinicians and patients for sure believe that manipulative techniques are done more efficiently when sounds are evoked. So I did a study with Josh Cleland, 2011, I think, where we looked with pupillometry, and we looked at the response of the pupils on a thoracic spine T3-4 manipulation. The outcome was that there was really no effect on the nervous system any different than when there were audibles or no audibles. At the time, some other folks had done some work on, including Josh Cleland, on audible pops and function, audible pops and range of motion, audible pops and pain. And it seemed that all these studies had a correlation, saying that it did not seem to indicate much. Now, fast forward, I started working at Florida Gulf Coast University, I'm going to say about 8-9 years ago. And not only did I noted that in our education format, students are still in search of this incredible audible pop versus a non-audible pop. If you look at study designs, people typically do a manipulation at a particular level. If there is no sound, then they do it again. And if there's no sound, they go to the opposite side and do it again. From my perspective, unfortunately, I think that makes it a very non-specific approach, just chasing this particular event of a pop. So a couple of years ago, we started thinking of, hey, maybe we should look at this one more time and put this pop situation to bed. Pretty much everything has been looked at except the brain. So as we are becoming more and more interested in the brain and brainwaves and functioning in all aspects of society, we got a grant from the Florida Physical Therapy Association, and we bought a very simplistic device, and we started kind of playing around with doing physical activities. And then we decided, okay, let's do this study where we actually repeat the thoracic 3-4 manipulation idea and now see what the brainwave responses are. It was really kind of born out of the fact that people seem to continue to look for the sound as that apparently has some magic. So that kind of led me to this idea.
Excellent. Thank you for that explanation. And you've already started to touch on this a little bit, but can you dive a little bit further into the machinery that you're using? In particular, how are you determining what's going on physiologically in the body during the manipulation technique?
Yeah, so that is the biggest challenge for us. We can look at other measuring tools, let's say like ultrasound imaging, and we can pick it up fairly quickly, right? But trying to identify what happens with brainwaves is a little more challenging. So we used an emotive Epoch Plus unit, very affordable. It has been shown to be having similar measuring capacity as larger machines. And this measured at about a frequency of 128 hertz. It's a small unit. It only has 14 electrodes, which is, when you think about the real measurements, you come with 20 or 32 or 64. But our thought was to just kind of get an idea. We have not a lot of funding available for us for research, so this is kind of what we had. And we started playing with it. The machine comes out of the gaming industry, where they looked at activities in the brain while people were gaming. That's kind of how it was developed. And now a lot of people, including universities, are starting to use this device. It's about $1,000, so it's not inaffordable. It has 14 electrodes. Now, under each electrode, you pick up 5 different wavelengths. And these 5 different wavelengths relate to certain particular activities in the brain. So what we were interested in, we weren't interested in looking at a medical diagnosis of, hey, is this normal or abnormal? But really what we wanted to look at, do the waves change? And do they change in a particular area of the brain? And then can we look at the other scenario, pop versus no pop, and see what happens in that area? We played with the thought of, if you do an EEG recording and you do an assessment, sometimes people only look at the peak changes that happens and have software that filter all that stuff. For me, that wasn't very user-friendly. So our idea kind of came down to the fact that we're just going to simply look what happens under these electrodes on both sides, and then relate that to the area of the brain. So that's kind of what we did.
As a physical therapist, to me, that's kind of it's a hard description, I suppose, to follow because I'm not used to working with an EEG to measure brain waves. And speaking of which, what was it like working with this type of equipment? Did you find it difficult or easy? And is this why you have a physician co-author on the poster?
It's actually a very good question. Yes, it was very challenging. We had a lot of technical problems. I think we went to 5 headsets. They break, you pull them a little too far. So we're not very familiar with that type of equipment. So we definitely had some challenges there. We had some challenges in contact, because these are EEG. You can do it in 2 ways. You can do a gel contact or a water contact. The gel contact is typically what you do when you get an EEG study at the hospital or some private clinic, where they put that glue on your head and they kind of stick it down. So this unit is not like that. This unit has little pads that you make wet. So we had a little difficulties in the beginning to figure out how much wet is enough. So that took us a little bit to figure out. As you said, indeed, the actual brainwaves is completely, I would say, outside what we definitely, maybe even our scope, what we kind of look at. The thought that we could do it anyway, we've been very interested in, the brain interface to machine. So not only have we now done these, but we've also looked at yoga and brainwaves. We looked at strength exercising brainwaves, bike and brainwaves. So we've done a whole bunch of these series now to see if we can map where what happens. So it was all brought kind of forward out of the brain mapping. A young lady who's actually MD on the study is not a practicing MD. She, for instance, one of the things that she did besides working on the manuscript is she made the images. So medical illustration more than anything.
And presumably, the more you work with the equipment, I would think you're getting maybe better and quicker and more confident with it.
Absolutely. Yeah, it's like anything else. It's a learning curve.
And are you able to speak to the clinometric properties of this type of testing? Just like we always talk about in physical therapy, like how reliable, et cetera, is the EEG equipment?
Okay, so the unit that we used, that has been developed by Emotive, has been found reliable and comparable to big machines that sit in offices and are the golden standard. So from my experience, what I see when working with this, I think it has its limitations. It only has 14 electrodes. But for what we were looking for, I think it did its job and was okay. And I think phase validity is certainly there, because we're not interested so much in the meaning of the waves, and we're more interested in the amount of waves.
That's super interesting, and it leads right into my next question. During this pilot study, was the equipment able to pick up on the difference between a manipulation scenario where the audible pop was acquired and one where it wasn't? And if so, what was the difference between these two groups that the testing equipment was able to pick up on?
Yeah, it's a good question. So there were some surprises, which we have no answers for. So for instance, when you do the audible pop, one would expect that the brain region by the ear would be more active. And that actually is not what we found. So that made us kind of think, well, maybe the pop sound is not what it is. Maybe it's the bone to bone transition throughout the body that comes with that. Maybe that's what bringing it out. So that was something that we kind of did. So it wasn't between the two groups that really didn't change much. What we did see in the audible pop is that frontal lobe activity through pretty much all waves went significantly up. In the non-audible pop, that was a little bit less. So the thought was, can we relate these regions? And then say, okay, so when you do a manipulation, where does one expect some activities as it comes down to these two? So our thought really was, after we looked at this, that the frontal lobe is definitely where the majority of changes took place. And it seemed like when we were doing some literature and comparing, that might indicate some like a relaxation, like a post-manipulation relaxation situation. And so what the challenge really was is when you brain waves are extremely fast, right? So any little change and it changes the picture of what you're seeing. So what we had to do is to standardize. Like for instance, when we did the manipulation, we placed the hand on the skin for at least 15 seconds ahead of time. And then when we did the manipulation, we kept the hand on the skin for the same amount of time so that we would not have interference of, well, maybe the hand moving gave the signal versus the manipulation. Manipulation is such a short episode of time, so we had to kind of figure out for a little while before we started data collection how we would keep that all the same. Like we went into a somewhat dark room so that the eyes are not picking up too much activity, and therefore the occipital lobes are becoming very active. So we had some of these things that we had to test. We did test also the room for electrical interference from anything else. It never really seemed to be there, but that was okay too. So yeah, I definitely think that the challenge was creating the circumstances to validate that you can have a conclusion.
And as two quick follow-ups, I'm assuming the differences that you saw between the two were statistically significant. So if you could speak to that, that would be great. And I'm curious to know, what do you think is the significance of the frontal lobe being involved when you're observing the brain waves?
So let's start with the last question that you had there. The frontal lobe, is kind of where the decision-making component is of your brain, and also where when there is a relaxed activity, you will see a change in activity in the waves. So when you think about the manipulation, and people typically say, "Oh, it feels good." Okay, I think that's what we picked up, is that feeling of, okay, that kind of feels good, by and large. Now, interesting was that we had quite some occipital lobe activity, and the patients were with the eyes closed, so we really didn't know where that came from either. But then when you start looking at some literature, and you see that some decision making actually comes even from the occipital area, it kind of made sense again for us. Now, we had an uneven number in our group, and that was kind of the result of our guessing ahead of time. So when I did my study in the past, we found that in about 70% of the manipulations, an audible pop was elicited. Tim Flynn, in a similar time area, did something, and his number was like 68, 69. So when we were starting to assign people to two groups initially, we had a little difficulties to saying, okay, how are we going to randomize this and still come up with, fairly equal groups? So we stepped away from that idea because of the unpredictability from the pop. So really what we did is we had one group, and then when we did the manipulation and they got a pop, they went to the audible side, and the other side went to the non-audible side. Okay, so we had like 20 and 37. In both groups, we found statistical significant differences under particular areas of the EEG. In the non-audible group, it primarily was in the frontal, parietal, and occipital lobes. In the audible group, there was significant change under all the lock traits in the frontal lobes, parietal lobes, and the occipital lobe, but not in the temporal lobe. So same areas for both, other than the temporal, which we talked about a little bit earlier, which is somewhat surprising because the sound, one would think, should have elicited at least something.
I might be a bit off topic with this next question, but based on what you were just saying about the frontal lobe, et cetera, being involved, would you anticipate that you might get different results if you were, or let's say statistically different results, if you were to compare people who like, appreciate, and want to hear the audible pop versus another group of people who might be fearful of it and not want it to occur?
Yeah, that's actually a really good question, and we gotten similar questions when we presented the poster. Yeah, I would say I have no doubt that might show. And the problem is in our groups we did not screen for that component, so we might have had a couple of those. But if you can identify a group and isolate them and then do the repeat, then yeah, it will be very interesting to see if we see something different. That's actually a very good suggestion.
Yeah, I would imagine it's the type of thing that you could really quickly add to a screening process as you're, going through your inclusion and exclusion criteria. And it could give you another bit of information to look at. And yeah, like I'm just asking the question because, based on your description, I think it would be fascinating to see if there's a relationship there. I agree with you. I think it seems like there likely could be, but it would be amazing to see the data on that.
Yes, it might shift a lot of what we're looking at. Again, there's one thing that when we were kind of playing around with these waves and these measurements is that it is so fast. Like, when I used to do more on the pupillometry research, I took an average over a minute, and, that was pretty fair, and you can still make some conclusion about the autonomic nervous system. It just doesn't go so fast. But these brain waves, and that's been a little bit our concern, you do a technique, you put some force, and they feel it. So instantly something changes in the brain. But now how long does that stay? Okay, so we picked completely arbitrary, 10, 15 seconds. So around 15 seconds in bed, most folks, initially we did some 10s. But their brain is already somewhere else. So the question is, do you lose the significant change because now the brain is occupied with laying on the table or feeling how the table feels or whatever, right? So we don't have a lot of good help for us to decide how are we doing some of this stuff because, not a lot of PTs use, of course, these kind of testing at this point. So that was kind of a challenge. So I think that, yes, it could have been that people were predetermined in what they thought they were going to feel, which could obviously influence their brain. And what if you did the manipulation and they started thinking about their grocery list, right? And frontal lobe activity comes as a result of that. I've not found a way how to avoid that wandering brain negatively affect what we're doing.
That's all super interesting. And as we always like to do on the podcast, let's try to bring this back to a clinical question. And that is, yes, this information is super interesting from a physiological perspective, but what importance do you think that this information has when we relate it back to what we're doing in the clinic with our patients?
Well, I think we need to ask ourselves a couple of questions as a profession and those that manipulate joints. I think that this, again, for me, adds to the side of evidence that says, audible pops maybe have not much input, in this case in the brain. We already know that it didn't have not much input on some of the other components. So we should feel very strengthened in our thoughts that if I don't have an audible pop, that's okay. And students especially need to learn that that's okay. We're not chasing the golden egg here by having an audible pop. that has to be relevant clinically. The next question we then do is, what if you do repeated manipulations? Because that's if you start chasing sounds, right? That's a risk. And when you go into these grade 5 repeatedly, and one would think about, like, say, some simple concept like a stress strain curve, at some point you're going to get a plastic change in tissue, in theory, right? If that's the case, am I now helping my patient or am I not helping my patient? Just because we're chasing something that really nobody has actually shown per se at this point that it is better than the other. So, apply your grade 5 application, make sure that your position is well and you feel that it was carried out correctly, and then move on. Don't go back and do it again. Unless your hand position wasn't right, you kind of felt like, hey, this wasn't right. By all means, you can repeat the procedure. But the clinical application has to be, we have to stop chasing something that makes no difference.
I think that's a great answer. And just to add a tiny little bit to what you were saying, you mentioned, educating students, for example. And of course, if we take that one step further, we could also, of course, use information like this to educate our patients, because so many of the patients come in wanting, demanding, needing to hear that audible pop. And, sometimes it's just not what they need.
Yeah, absolutely. The question, though, is how do you change their perception of this? I've been primarily in spine care for the last, say 25 years. And when I started in 2011 looking at some of this stuff and identifying, hey, it makes no difference, I would go into discussion with my patients and saying, what are you talking about? It's fine. It's real difficult because they have that in their head somewhere. They might have been to another provider that has mentioned that, or whatever the reason is they think that. Changing human behavior is very challenging. If we can change human behavior, physical therapy outcomes would be better in the first place. But I think we need to, one at a time, we need to inform people that that's just not necessary.
So, of course, as we began this conversation, we mentioned that this was a pilot study. And I know you have some other things in the works right now, because, of course, pilot studies are just how we get a line of research started. Can you speak a little bit to how this information that you've gathered from the pilot study has transitioned into additional and subsequent studies?
Yes. So once we got looking at the results, we said, okay, so thoracic spine might do this, but will the same apply to a lumbar spine? So we have completed a project on doing the same thing with exactly same measurement approach to a side laying rotation manipulation in L4-5. One of the problems that we run into is that the emotive is a headset. So when we lay him in certain positions, you get more pressure on that headset on the head. So we had to be very creative in how we position patients. So we completed that one. And we just finished data collection on the cervical spine, because I wanted to kind of do thoracic. If we're going to do lumbar, then we have to do cervical. So we just completed that. Cervical, we added in an additional piece, which goes back to some of my original studies. I put the pupillometry back on the patient, and then we put the EEG unit on the patient. And what we're doing is we're measuring the effect of the manipulation on the brain. We're looking again for the audible effect on the brain, but we're going to try to correlate it to either a sympathetic or parasympathetic tuning at the same time, which might strengthen a little bit instead of using at one neurological component of brainwaves, we'd like to see if we can correlate this to the autonomic nervous system balance between para and sympathetic, so that we can have an additional support for some of the things that we're seeing.
I find that all to be super fascinating and interesting. I will certainly look for publications and additional work that comes out of this line of investigation. And that point having been made, Dr. Sillevis, this has been a truly wonderful and intriguing conversation. Thank you for bringing your expertise and this information both to the podcast and to our audience.
Thank you very much for having me. I would enjoy talking to you again in the future.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.